Nutrition science evolves through milestones, moments when evidence deepens and practice transforms. Welcome to Milestones in Pediatric Nutrition, a podcast by the Nestlé Nutrition Institute, hosted by Professor Andrew Prentice. In each episode, leading experts reflect on breakthroughs that shape modern nutritional care, from early life feeding to practice-changing interventions across the life course. Because progress happens, one milestone at a time. This festive season, join us as we celebrate the discoveries that continue to improve children's health worldwide. Welcome to Milestones from the Nestlé Nutrition Institute, your daily dose of breakthroughs in pediatric nutrition this holiday season. Today, Professor Andrew Prentice is joined by Professor Keith West to discuss universal vitamin A, the public health impact of large-scale supplementation, a milestone shaping the future of child health.
Welcome to our new podcast series, Milestones in Pediatric Nutrition. This is part of a wider series of NNA Bites Big Learnings. My name is Andrew Prentice, and it's my great pleasure to welcome my longtime friend, Professor Keith West from the world-leading Johns Hopkins University in the USA. Keith is here to describe the history and current status of vitamin A supplementation, universal vitamin A supplementation. We could have no better person to do this. As one enters the Bloomberg School of Public Health in Baltimore, where Keith is based, you see the vision statement that reads, "Protecting health, saving lives, millions at a time." And universal vitamin A supplementation has quite possibly done just this. Keith, thanks so much for joining us.
It's a pleasure to be here with you, Andrew. Thank you for inviting me.
So before I list your very many achievements and accolades, I thought we'd have a bit of a sort of recollection of some of our meetings. Perhaps you have a better memory than mine and recall when we first met, Keith.
You know, we're both having an aging moment here.
I thought we might.
But I know it's been a long time. We're friends for decades.
It's been a long time. And one of my first memories is of you bringing out your guitar and entertaining us one evening at the ICDDRB rest house in Dhaka, Bangladesh, a country you know very well because I believe you lived there in the 1970s.
I've been going back and forth for half a century to Bangladesh. Yeah.
Tell us about your well-traveled guitar and how many air miles it has notched up.
Yeah, it has almost as many as I do. I actually keep a guitar in Bangladesh, so I don't have to travel with one anymore. But I find that music and public health go together. And when I need to divert from a hard day's work and lots of thinking and lots of work, there's nothing like some music at night to just relax and bring perspective.
I'm so envious as a non-musician. In fact, as we were preparing for this podcast, Keith was telling us a wonderful story about how he jammed with Cat Stevens many years ago in Bangladesh and how that led to some wonderful philanthropic contributions from Cat Stevens to Concern International. Unfortunately, we don't have time to go into that today, but it was a marvelous story. Another favorite memory is when we were privileged to have dinner at the Bloomberg School with Dikembe Mutombo, the 7-foot, 2-inch NBA Hall of Fame basketball player who had been awarded the Gudamote Humanitarian Award for his contributions to health in his home country of Congo. Keith, you tell me you don't remember that very well, so let's move on.
But I do remember inviting you to a George Graham lectureship because of your international standing and contributions in public health.
Which was most gracious of you, and I have that plaque sitting on my desk to keep me inspired. Professor West did his graduate training at Hopkins, qualifying with his DRPH in 1986, and has been a very loyal alma mater, rising to become the inaugural George C. Graham Professor of Infant and Child Nutrition, a post he has held for some 20 years. His work has been recognized by very many awards, of which I would highlight two very special ones from the American Society of Nutrition, the Kellogg International Nutrition Prize, and being elected a fellow, which is the Society's highest honor. With over 400 peer-reviewed publications, Keith's work has been hugely influential in the whole field of maternal and child nutrition, with an emphasis on micronutrient interventions. He's a world expert on vitamin A. So, Keith, thank you for being with us again. I'd like us to start, if you would, with a very brief, I think you Americans call it a 101 on vitamin A and the effects of its deficiency on human health.
Well, I'd be pleased to. We have known about vitamin A for now over a century. For those of us at Johns Hopkins, we related very closely to a discovery by E.V. McCollum in 1913 of a fat-soluble substance that was required for small animals, small rodents to grow and to maintain healthy eyes. That was in 1913. The School of Public Health opened up in 1916. In 1917, McCollum became our first professor in the field of nutrition. So there's a long-standing institutional relationship to this essential nutrient that participates in so many physiological functions. It's almost a nutrient that had to be called vitamin A when micronutrients started to be discovered. We know that in deficiency, there are many aspects of our normal physiology that become dysfunctional. Vitamin A is required for normal epithelial function and maintaining epithelial integrity of multiple tissues, of maintaining a normal immune response, such that when individuals are deficient, there can be an increased risk of infection because of compromised immunity. Epithelial linings become metaplastic and can keratinize. We see that most obviously in the eye, on the anterior segment of the eye. The eye is not just the windows of the soul, but it is the windows of epithelial linings in the body as well. And so in vitamin A deficiency, you see metaplasia and keratinosis on the conjunctival surface. If it becomes severe, it can be seen on the corneal surface, and that becomes a potentially blinding condition. So we know that vitamin A deficiency leads to an increased risk of infection, but more likely severity of infection rather than incidence per se. And we know that the eye conditions, the stages of xerophthalmia can be traced to increasingly severe levels of vitamin A deficiency. The other function of vitamin A, besides in the surface of the eye, is its participation in the visual cycle as a cofactor in rhodopsin that is required for vision under conditions of low light, such that if an individual's vitamin A deficiency, then night blindness, a condition called night blindness, can occur. Most commonly in young children, but also in women during pregnancy, during the high nutritionally demanding phases of late pregnancy in particular. Women can become night blind in undernourished populations. The condition then typically goes away after the child is born, after the placenta is expelled, and those metabolic hotbeds are no longer there, and the night blindness may resolve, but vitamin A deficiency can continue in women. So it is a nutrient that is essential for so many functions and can become deficient when the diet is inadequate. And we know that there are two main sources of vitamin A. There's a preformed vitamin A, and there are provitamin A carotenoids in plants. The carotenoids are yellow-orange pigments, and so we find the provitamin A carotenoids in foods such as ripe mangoes and papayas and carrots. Mm-hmm. We also see it in the major sources, dark green leaves, and they're not orange, but the pigment is embedded below the chlorophyll of the cells, and so you have these foods that are excellent sources, but they are seasonally available at times, or they may be expensive, and therefore, dietary deficiencies can lead to the consequences of vitamin A deficiency.
Pathology. Yeah. So I'm kind of hoping that most of our listeners will have not seen a case of severe vitamin A deficiency, but roll the clock back for us 50 years or so to when you started in Southeast Asia, and just briefly describe some of the awful pathology that was so widespread then.
Yeah, so if you go back to the 70s, it was known at that time that vitamin A deficiency would cause night blindness, which was considered and is considered a mild eye sign because it's reversible readily in a few days due to a deficient diet in vitamin A. The epithelial metaplasia that can occur on the anterior segment of the eye also can be called mild xerophthalmia if it happens on the conjunctiva. And at that stage, it's mild xerophthalmia, it's non-blinding, it's responsive to vitamin A supplementation, and that is the predominant ocular stages of deficiency. However, when there is especially concurrent demands on nutriture that can occur with severe infections such as measles or malaria, other febrile illnesses, that can exacerbate the losses of vitamin A from the body, and eventually, if it's severe enough, the cornea can become involved, and there would be keratoses that would occur on the cornea. Eventually, that if it gets severe, that can lead to other ocular signs, perforation of the cornea, ulceration of the cornea. It can lead to stromal edema. It can cause scarring of the corneal stroma, and that leads to what we call keratomalacia, the softening of the cornea, and that's a blinding condition. Vision can be protected if early in the process, if a child is given vitamin A. But at some point when the condition is severe, it becomes blinding, and there is no real therapy for that. That's a blind child at that point. So we know it's the most preventable cause of childhood blindness in the world, and that still is true and can be true forever, because nutritional deficiencies are really never eradicated. They can always come back.
Okay, so that's a really good description and quite a deep description of how we end up with the ocular manifestations and how widespread those were. But then there was a turning point in around the 1980s, I think, another fundamental discovery by the Hopkins team and by someone whom I know you admire greatly as one of the true giants of nutrition, Alfred Sommer. And summarized beautifully in a book that you co-authored with Al some 30 years ago, Vitamin A Deficiency, Health, Survival, and Vision. Tell us about that next step.
Yes. So it's an interesting part of history and politics and nutrition. At the World Food Conference in Rome in 1972, Henry Kissinger was giving a speech. And he was giving this speech, and the nutrition officer at USAID, Marty Foreman, scribbled onto Kissinger's notes a few lines that said that the United States was committed to preventing the scourges of iron deficiency anemia and vitamin A deficiency. And that was at a time when a Secretary of State said something, and there was actually action that followed. And within 3 weeks of that early November meeting, there was a meeting in Jakarta. WHO, USAID, Helen Keller, UNICEF got together to start planning a research program that would illuminate the prevalence, the severity, and the consequences of vitamin A deficiency. Al Sommer joined that process at that time, ended up going to Indonesia and carrying out longitudinal studies in Java. And those longitudinal studies were particularly important because one of them showed that children with examined with night blindness or Beteau spots, the mild conjunctival xerotic process in the eye, and the two conditions combined, forming a dose-response relationship, was related to a dose-response relationship also with mortality. It was observational. It was there stratifying children by various factors. So epidemiologically it was strong, but the causation was not clear. I joined Al and the International Center for Epidemiologic and Preventive Ophthalmology at Hopkins at the Wilmer Eye Institute in 1980-81. And we worked with our Indonesian colleagues to go back to Indonesia, set up a large trial in Aceh province, which is the northern tip of North Sumatra, northern tip of Sumatra. And we carried out a 28,000 child, 450 village trial to look at the impact of giving vitamin A on child mortality. At that time, the Indonesian program was rolling out. It was not placebo controlled, but we were able, rather than to select villages that would get the program or not, we were allowed to randomize them. Mm-hmm. And so we randomized these villages to the program or not to the program and followed these children, enumerated and followed them over a 1-year period, taking particular care to enroll, consent, enumerate, and follow those children. And it led to a 34% reduction in child mortality, preschool child mortality. It was a dramatic finding and created a stir in the nutrition field. Those who believed it, those who didn't believe it, and everybody in between. It did create a lot of excitement, though. And so at the International Congress of Nutrition in Brighton, England, in 1985, just when this study was finishing, Jean-Pierre Habit, a very famous nutritionist, was due to give the keynote speech at Brighton. And when, on learning about the findings from the Aceh trial, J.P. Habit gave his keynote time to Al Sommer.
Oh my goodness.
And so at Brighton, in the first presentation of the whole Congress, people heard about the impact of vitamin A on child mortality. It was the discussion point for the rest of the meeting in terms of whether it could be true, can't be true, what's wrong with the data, how can this be? Children need so many other health interventions. But it stirred a hornet's nest of interest. And also what is needed in good science, and that is replicative studies. And so thereafter, there were several trials, one that we were fortunate enough to also do with our colleagues in Nepal from 1988 to 92. But there were trials in India and in Ghana and in Sudan, looking at a further trial in Nepal, looking at this impact of vitamin A, either supplied as a supplement every 4 to 6 months. Vitamin A is stored in the liver, and it is a critical part of the physiology of vitamin A that allows a public health intervention to proceed every 4 to 6 months rather than it be daily. Yeah. Nonetheless, there were trials that did the 4 to 6 month intervention, a weekly smaller dose in South India, and fortification of monosodium glutamate in Indonesia, which would be a daily. So it tested the whole range of intakes of vitamin A. And 6 out of those 8 trials showed a significant reduction in child mortality. And when meta-analyses were done, the first one being done by George Beaton and presented in 1992, the overall impact was found to be anywhere from 23% to other meta-analyses that showed a 30% reduction in child mortality. That led to programs around the world. Ocular disease and blindness are important, but child mortality brought entirely new constituencies into view and wanting to participate. The way that it was promoted and organized to get the message out at that time was through a meeting, the Bellagio meeting in 1992, which brought investigators from around the world to come up with, review the evidence and to issue statements.
Let me just tell the listeners that Bellagio is a wonderful place in Italy where the Rockefeller Foundation hosted special meetings like this, meetings of minds and experts that could pull together on a single topic, and has really, not just in this case, but in other cases also, made significant progress. And before I allow you to go on, Keith, I just want to, because I hope that many of our listeners will listen to several of our podcasts, and so this story resonates so well with the hierarchy of evidence. So you've just described starting off with an observational study, moving into the first clinical trial, replicating in other clinical trials around the world, doing a meta-analysis, and then we come to the point that I'll now let you take forward again, please, what you do with that evidence, how you make that into a really, global campaign.
Right, good question. What we did at that time through this special meeting was to come up with consensus statements. Consensus statements that would be clear, actionable, well understood, and that could drive policy. Now, we didn't have the internet at that time, but what we did do was the investigators went out and there were short reports published in major journals throughout the world to get the word out at that time. It may seem slow and limited, but it was also at a time when there was far less noise in terms of the information world, and the signal got through. It drove bilaterals, UN agencies, and government ministries of health to take interest in this intervention, especially since the intervention involved a supplement, a capsule of vitamin A that could provide a 6-month supply to children, costing 2 cents, and delivered into the community. It was a straightforward intervention, and it gained a lot of interest. And so with that, the program scaled up to, I think it reached about 85 countries around the world, where preschool age children were given vitamin A every 6 months as a means to reduce child mortality due to febrile illnesses, diarrhea, dysentery, and measles were the main diseases that were shown to, or just, symptomatic diseases that were shown to respond to vitamin A supplementation. That has continued. The supplementation can address the public health consequences of the deficiency, but does not resolve the cause of the deficiency. And so there has been a lot of work on fortification of foods with vitamin A, as foods are technically and feasibly fortified and available to the poor. There has been work on carotenoid biofortification of crops to increase the provitamin A content of the diet. And so there's been a rollout of other kinds of programs along the way that are complementary.
Yeah, but nonetheless, the supplementation per se is still really, has been for so many years. And when I go to, clinics in the Gambia, I'm always really gratified to see the staff there who really believe in this. They're giving the vitamin A. They believe absolutely in it. And it's, as you've said, it's such a simple intervention. Right. So, Keith, I wonder, do we have any estimates of how many lives have been saved?
Well, we published some papers in the 25 years ago when the evidence was fresh and strong, estimating that 1 million child deaths could be averted every year with programs. Those estimates haven't been quantified in recent years. And it may be that child mortality rates have come down, possibly because, in part, of the vitamin A status of children, rising as a result of not only the capsule program, but the other dietary interventions, especially along the way. So one has to revisit the evidence keep on top of it. Policies are driven by evidence, but then policies can change. And I refer to them as a policy garden. You have to weed the garden every once in a while in terms of keeping the signal strong as is merited to keep the policies going. And so the supplementation program remains important, perhaps especially in this age of anti-vaxxing sentiment. Right now in the United States, we have our biggest measles epidemic unfolding in 30 years. And given that vitamin A can reduce case fatality of measles, the importance never really goes away. It just shifts from one place to another or from one time to another.
Indeed. That was a point about measles that we didn't bring in earlier, actually. But of course, vitamin A is, absolutely seen as an adjunctive therapy for measles. And it's so, so important.
Right. And even in the United States, the American Academy of Pediatrics still has vitamin A supplementation as a treatment for measles on the books.
And we've unfortunately got outbreaks of measles in the UK. What I would tell you is a horrible story from 50 years ago in the Gambia. When we got there, there were massive measles outbreaks that would kill a third of the children in single villages. So we tend to forget this, but the vitamin A supplementation has been part and parcel. Of course, immunization has been the most important thing, but vitamin A has been part and parcel of it. Right. Now, I'm going to touch on something which I think still remains a little bit painful for you, Keith, which is that you and I were part of a consultation at WHO in Geneva, I can't remember, a couple of decades ago probably, which looked at the evidence around neonatal vitamin A supplementation. So the question was this: if we start giving vitamin A at 6 weeks or so, and we're saving lives, what if we gave it earlier? Could we save more lives? And I think it was the Gates Foundation, correct me if I'm wrong, but they sponsored 3 very large trials. I think there was certainly one in Ghana, Tanzania, was it, and one in India. And so we were reviewing the evidence from that, and it came out that it appeared that in India there was a strong protective effect. In Tanzania and Ghana, there was no significant evidence of protection. And take the story on from there, because I remember that you were, and still are, pretty exercised about the outcome of that.
Right. So there was an early trial in Indonesia published in 1996, Jean Humphrey et al. With Indonesian colleagues in Bandung, showing it was a small trial, but there was a significant reduction in infant mortality. It was published in Live Fallow for several years. That was the first evidence to suggest that newborn vitamin A, neonatal vitamin A, could have an impact on infant mortality. Infants are born with low vitamin A stores in the liver everywhere in the world. It's just that their levels climb much faster in well-nourished populations, breast milk levels, other ways of feeding infants. Their stores go up, literature goes up, which doesn't happen so readily in impoverished and undernourished communities. That was followed up, though, eventually by another trial in South India at the Aravind Children's Hospital by Lakshmi Ramatula, showing in not 2,000, but now around 11,500 infants that giving vitamin A at birth versus not, versus a placebo, reduced infant mortality by something like 15%, 23%. And so that began to put more evidence on around this issue. When that trial was published in 2003, we immediately took the issue up in Bangladesh, where we were running large trials in northwest Bangladesh and carried out another placebo-controlled newborn vitamin A intervention, 50,000 international units or placebo at birth or shortly thereafter. And that led to around a 15% reduction in infant mortality. That's when the WHO trials kicked in. There had already been 3 trials that successively showed that in the southern Asia, newborn vitamin A could reduce infant mortality. The trials that were sponsored by, that were coordinated by WHO, the trial in India showed a reduction of 10%, 10 or 11% in infant mortality in the slums of Delhi. And the trials in Africa showed no effect. There was one further trial in Pakistan that was an excellent trial, but it really wasn't an efficacy trial. It was a program evaluation. When mortality is the outcome, if there's proper and frequent care given to children and they get referred for severe illnesses, that changes the calculus of what a supplement can do. The basic finding, though, was that in Southern Asia, giving infants vitamin A in the neonatal period reduced infant mortality, and in Africa it didn't. What do you do with that information? Well, some put it all together and carried out meta-analyses of all of that information together, and you put a continent of impact and a continent of non-impact together, you end up with an estimate that is not significantly different from the null. However, it was acknowledged, at least, that there was this difference in mortality in between the continents, and so whereas the childhood vitamin A supplementation rocketed around the world to where it was needed to reduce child mortality, the newborn vitamin A supplementation effort has gone nowhere in the past 20, 25 years. And it reminds me of Einstein's aphorism of, make things as simple as necessary, but not simpler. In this case, I would ask, if he was alive, I would ask him what should be done. And I suspect he would say, vitamin A supplementation of newborns reduces infant mortality in South Asia. It doesn't do it in Africa. Supplement the babies in South Asia and don't supplement them in Africa.
Well, exactly.
And so, that hasn't happened, though. And so we've estimated that 165,000 babies could be saved every year throughout Southern Asia with, 8 drops of oil of vitamin A given shortly after birth.
Good. Well, Keith, I'm very keen not to end on what is kind of sad story in a way. One that
a story that's unfolding.
It's unfolding, yes, exactly. And I was going to say that I'm sure you will continue to fight that battle, and I wish you luck in it.
Yes.
In terms of, going back to the hierarchy of evidence, what it tells us is that meta-analysis needs to be viewed intelligently. You shouldn't be mixing apples and pears. Separate out the apples from the pears, do your meta-analyses in the 2 different continents in this particular case, and apply the public health message accordingly. But let's get back. I'm going to summarize now because we've run out of time, but what you've told us is an amazing story, and thank you so much for bringing the personal aspect of it, the real history, the lived history that you've gone through of this amazing, possibly the most important initiative in terms of global nutritional interventions that there has ever been, and that has saved, we don't know how many, but certainly millions of lives. Keith, congratulations for your part in it, and thank you so much for sharing that story with us.
Andrew, thank you. It's been a real pleasure to have this opportunity to chat with you.
We'll be back soon with more episodes of Milestones in Pediatric Nutrition, part of the wider series of NNI Bites Big Learnings. And to make sure that you don't miss any of the future ones, please visit the NNI website or download the NNI 365 app and sign up for them.
Thank you for joining us on Milestones. For expert-led discussions, scientific publications, and educational resources, visit the Nestlé Nutrition Institute website. Follow us on our social channels and subscribe to never miss an episode. Join us again tomorrow as we take nutrition science further, one milestone at a time. Wishing you a season of learning and discovery.